Page 150, Chapter 24 in Pulmonary Embolism. Expected findings are anxiety, feelings of impending doom, sudden onset of chest pressure, pain upon inspiration and chest wall tenderness, dyspnea and air hunger, cough, hemoptysis. Physical assessment findings could be pleurisy, pleural friction rub, tachycardia, hypotension, tachypnea, adventitious breath sounds, crackles, and cough, heart murmurs in S1 or S3 and S4, diaphoresis, low-grade fever, decreased oxygen saturation levels, expected reference range is 95 to 100%, low SAT-O2 cyanosis, petechiae, red dots under the skin, over chest and axilla, distended neck veins, syncope, and cyanosis. Laboratory tests would include ABG analysis. PaCO2 levels are low. The expected reference range is 35 to 45 Hg due to initial hyperventilation, which causes respiratory alkalosis. As hypoxemia progresses, respiratory acidosis occurs. Further progression leads to metabolic acidosis due to buildup of lactic acid from tissue hypoxia. The D-dimer test is elevated above expected reference range in response to clot formation and release of fibrin degradation products. Expected reference range is less than 0.4 micrograms per milliliter would be normal. The diagnostic test would be a CT scan, that's computed tomography scan. The multi-detector row computed tomography angiography MDCTA is the criterion standard for detecting PE when available, because it provides high-quality visualization of the lung parenchyma. The next test would be ventilation perfusion scan, which is a V/Q scan. Images will show circulation of air and blood in the lungs and can detect a PE, pulmonary embolism. This is useful when the client is allergic to contrast media with the CT scan, and that's a contraindication to other types of imaging. So they could do a ventilation perfusion scan. The pulmonary angiography is a gold standard test when MDCTA, which is the multi-detector row computed tomography, is unavailable to detect a PE. But the pulmonary angiography is invasive and costly. A catheter is inserted into the vena cava to visualize the embolus. Pulmonary angiography is a high-risk procedure more than a V/Q scan, the ventilation perfusion scan. Nursing actions would be to verify that the informed scent has been obtained, monitor status, vital signs, SaO2, anxiety, bleeding with the angiography during and after the procedure. Another diagnostic test would be for the PE is a chest X-ray, which can provide data to support the occurrence of pulmonary embolism, such as elevation of the diaphragm on the affected side or shows pleural effusion. Patient-centered care. With nursing care, you would want to administer oxygen therapy to relieve hypoxemia and dyspnea, shortness of breath. Position the client to maximize ventilation at a high Fowler's at 90 degrees. Initiate and maintain IV access. Administer medications as prescribed. Assess respiratory status at least every 30 minutes. Auscultate lung sounds. Measure rate, rhythm, and ease of respirations. Inspect skin color and capillary refill. Examine for position of trachea. Assess cardiac status. Compare blood pressure in both arms. Palpate pulse quality. Check for dysrhythmias on the cardiac monitor, TELE. Examine the neck for distended neck veins, inspect the thorax for petechiae, and provide emotional support and comfort to control client anxiety. Monitor changes in level of consciousness and mental status. Medications start with anticoagulants, which is unfractionated and low molecular weight heparin. Enoxaparin, which is Lovenox, and warfarin are used to prevent clots from getting larger or to stop additional clots from forming. Nursing actions are to assess for contraindications, which would be active bleeding, peptic ulcer disease, history of stroke, or a recent trauma. This would be contraindication to getting anticoagulants. Monitor bleeding times, prothrombin time, PT, and international normalized ratio INR for warfarin. Partial thromboplastin time, which is APTT, is for heparin. And the complete blood count, where you would get an H&H. Monitor for adverse effects of anticoagulants such as thrombocytopenia, low platelet count, anemia, and hemorrhage. Direct factor XA inhibitor is another medication that can be given for PE, blood clots, rivaroxaban, axpixaban, and fondaparinux. These bind directly with the active center of factor XA, which inhibits the production of thrombin. Nursing actions would be to assess for bleeding from any site. Clients have experienced epidural hematomas as well as intracranial, retinal, adrenal, and GI bleeds. Hold this medication for 18 hours prior to and 6 hours after the removal of an epidural catheter. Another medication would be direct thrombin inhibitor, such as dabigatran, dabigatran. This acts as a direct inhibitor of thrombin. Nursing actions would be to assess for bleeding and manifestations of blood loss. Thrombolytic therapy, such as Altiplaz, Retiplaz, and Nectiplaz, are used to dissolve blood clots and restore pulmonary blood flow. Similar adverse effects and contraindications as anticoagulants. Nursing actions would be to assess for contraindications, known bleeding disorders, uncontrolled hypertension, active bleeding, peptic ulcer disease, history of stroke, recent trauma, or surgery pregnancy. Monitor for evidence of bleeding, thrombocytopenia, and anemia would all be indications of the loss of blood. Monitor blood pressure, heart rate, respirations, and oxygen saturation per facility protocol before, during, and after administration of this medication. Interprofessional care would include cardiology and pulmonary services such as consulted to manage a PE and treatment, utilize respiratory services, which should be consulted for oxygen therapy, breathing treatments, and ABGs. Radiology should be consulted for diagnostic studies to determine a PE.